Diabetes affects approximately 37 million Americans and over 537 million adults worldwide, making it one of the most prevalent chronic diseases in human history. Yet despite its familiarity, the underlying biology is often poorly understood. Diabetes is not one disease but a family of conditions sharing one feature: abnormally high levels of glucose in the blood. Chronic high blood glucose, hyperglycemia, damages blood vessels and nerves throughout the body through a cascade of biochemical mechanisms, leading to the serious complications associated with the disease. To understand why glucose becomes elevated, you first need to understand insulin, what it does, how it works at the cellular level, and what goes wrong in each type of diabetes. Insulin is a hormone produced by specialized cells in the pancreas called beta cells, located in clusters of cells known as the islets of Langerhans. After you eat a meal and carbohydrates are digested into glucose, blood glucose levels rise, and the beta cells respond by releasing insulin into the bloodstream. Insulin functions as a key. It binds to insulin receptors on the surface of cells, primarily muscle, fat, and liver cells, and triggers a molecular signaling cascade inside the cell. The critical downstream effect is the translocation of a glucose transporter protein called GLUT4 from inside the cell to the cell membrane. Once GLUT4 is in the membrane, glucose can cross from the bloodstream into the cell, where it is used for energy or stored as glycogen. Without insulin, GLUT4 stays sequestered inside the cell, and glucose accumulates in the blood. Type 1 diabetes is an autoimmune disease. The immune system mistakenly identifies the beta cells of the pancreas as foreign and mounts a sustained attack that destroys them over months to years. By the time symptoms appear, typically 80 to 90% of beta cell mass has already been lost. With no beta cells, there is no insulin production at all. Without insulin, cells cannot take up glucose. The body, sensing starvation, begins breaking down fat for energy in a process that produces acidic byproducts called ketones. When ketones accumulate rapidly, the result is diabetic ketoacidosis, a life-threatening condition with symptoms of extreme thirst, frequent urination, nausea, and confusion. Type 1 typically presents in childhood or young adulthood, though it can occur at any age, and requires lifelong insulin replacement therapy. Type 2 diabetes follows a different pathway. It begins not with the destruction of beta cells but with a phenomenon called insulin resistance. The target cells, muscle, fat, and liver, become less responsive to insulin's signal. The exact mechanisms are complex but involve chronic inflammation, accumulation of fat in muscle and liver cells, and disruption of the intracellular signaling pathway that normally triggers GLUT4 translocation. In response to insulin resistance, the beta cells work harder, secreting more and more insulin to compensate and keep blood glucose in range. For years or even decades, this compensation works. Blood glucose remains relatively normal while insulin levels are elevated. But beta cells have a limited capacity, and eventually, after prolonged overwork, they begin to fail and lose mass. At that point, insulin production falls, blood glucose rises, and type 2 diabetes is diagnosed. A key diagnostic tool in diabetes management is the hemoglobin A1C test, abbreviated HbA1c. Glucose molecules in the bloodstream attach spontaneously to hemoglobin, the protein in red blood cells that carries oxygen, in a process called glycation. The more glucose present over time, the more glycated hemoglobin accumulates. Because red blood cells live approximately 90 to 120 days, the HbA1c level reflects average blood glucose over roughly the past 3 months, providing a picture of glucose control that a single spot measurement cannot. The same glycation process that makes HbA1c useful as a biomarker also explains much of the tissue damage in diabetes. Glucose spontaneously glycates proteins in blood vessel walls and nerve cells, progressively damaging their structure and function. This microvascular damage drives the 3 major complications: diabetic neuropathy affecting the nerves, nephropathy affecting the kidneys, and retinopathy affecting the retinal blood vessels of the eye. Metformin, the most widely prescribed medication for type 2 diabetes, works not by increasing insulin but by activating an enzyme called AMPK, adenosine monophosphate kinase, in the liver. AMPK is a cellular energy sensor. When activated, it suppresses the liver's own glucose production, a process called gluconeogenesis, which normally adds to circulating glucose levels between meals. This mechanism is distinct from insulin. Metformin works on the liver's output rather than on glucose uptake in peripheral tissues. Newer drug classes target the disease from additional angles. GLP-1 receptor agonists mimic a gut hormone that stimulates insulin release and reduces appetite. SGLT2 inhibitors cause the kidneys to excrete excess glucose in the urine. The diversity of modern diabetes drugs reflects the multiple biochemical pathways that converge on blood glucose regulation, and understanding those pathways is what makes rational drug development possible.